Welcome to the deep dive. Today, we're plunging headfirst into a topic that, well, it's rare, but clinically, it carries enormous weight. Visceral artery aneurysms.
That's right. These are hidden dangers, really.
Mhm.
Despite being uncommon, they pose an extreme diagnostic challenge and a treatment challenge, too.
Absolutely. And their potential for rupture is just devastating. We're talking incredibly high mortality rates, particularly for things like ruptured celiac artery aneurysms and historically splenic artery aneurysms in pregnant women. I mean, that was approaching 100% mortality.
It's quite remarkable how much our ability to even detect these lesions has improved, though. Thanks to the sophisticated advancements in intra-abdominal imaging, MRI, MRA, CT, CTA, we're identifying these aneurysms much more frequently now.
Which is crucial.
Exactly. It's crucial because this diagnostic evolution allows for, well, better preoperative planning and, critically, the chance for elective treatment, moving us away from those really dire emergency situations.
That's a perfect lead-in. So today, we're taking a deep dive into the Society for Vascular Surgery Clinical Practice Guidelines on the management of visceral aneurysms. These guidelines meticulously describe the care for patients with these aneurysms, including evidence-based size thresholds for repair, specific open surgical and endovascular strategies.
And also that vital guidance on specific circumstances for repair at smaller sizes, like you mentioned, women of childbearing age, and false aneurysms, too.
Right. So let's talk about the foundation. How are these guidelines put together?
Well, the robust foundation here is the GRADE approach. That's grading of recommendations, assessment, development, and evaluation.
Okay.
And this system basically categorizes recommendations as either strong, which is grade 1, or weak, sometimes called conditional, that's grade 2.
And that's not arbitrary.
No, not at all. It's based on the quality of evidence, the balance of effects benefits versus risks patient values, and even resource considerations.
So grade 1 means?
Grade 1 means the benefit clearly outweighs the risk. High confidence for clinicians and patients. A grade 2 recommendation, on the other hand, means benefits and risks are more closely matched. So they're more dependent on the specific clinical scenario, physician preference, patient preference.
Makes sense. And the evidence quality.
Right. The quality of evidence itself is rated. A is high, B moderate, and C low. Now, high-quality evidence, grade A, is unlikely to change. But conclusions from low-quality grade C evidence are more likely to be revised down the line with more research.
Okay.
What's particularly interesting, I think, is that a strong grade 1 recommendation can sometimes be made even on low-quality evidence if the benefit is just overwhelmingly clear despite the limited data.
Got it. So given how comprehensive these guidelines are, our mission today is to provide you, our listener, a really detailed and synthesized understanding of two critical areas: renal artery aneurysms, RAAs, and splenic artery aneurysms, SAAs.
Yeah.
We'll cover the diagnostic tools, the criteria for intervention, treatment options, screening, follow-up. Basically, we'll try to ensure every negative insight from the source material is fully explored.
Sounds good. Let's dive in. Renal artery aneurysm, RAA. The deep dive.
Okay, let's start our deep dive with renal artery aneurysms, or RAAs. Their true incidence is, well, a bit elusive, isn't it?
It is, found in maybe 0.1% of the population. Autopsy studies probably underestimate it. Angiographic studies might overestimate it.
And the key thing is, most are silent.
Exactly. The vast majority are incidentally identified on imaging done for completely unrelated reasons, which, really highlights how revolutionary our better imaging has become. It turns those incidental findings into potential life-saving opportunities for elected treatment.
So when it comes to actually diagnosing RAAs, what do the guidelines say is the best approach?
Well, the guidelines are pretty unequivocal here. Computed tomography angiography, or CTA, is the diagnostic tool of choice. That's a strong recommendation, grade 1, supported by moderate quality evidence, so quality B.
And why CTA? What makes it so good?
It just excels with its multiplanar and three-dimensional reconstructions. It offers exceptional detail for assessing the arterial anatomy, even when the aneurysm is down in the pelvis or inside the kidney parenchyma. For the best definition, 1 millimeter thickness sections are preferred. And those three-dimensional views, they're particularly superior for visualizing branches compared to, say, older two-dimensional methods like catheter angiography or even ultrasound.
Okay, CTA is king. But what if you have a patient where CTA isn't ideal? Maybe radiation concerns or renal insufficiency?
Right, good question. For those patients, non-contrast enhanced magnetic resonance angiography, or MRA, is the recommended alternative. This is also a strong recommendation, grade 1, though it's based on lower quality evidence, quality C.
And who benefits most from this non-contrast MRA?
It's especially well suited for children, women of childbearing potential, or really anyone with contraindications to the contrast agents used in CTA or conventional MRA.
Mm.
So pregnancy, renal insufficiency, gadolinium allergy.
Are the techniques good?
Yeah, techniques like breath hold, steady-state free precession sequence, or time-spatial labeling inversion pulse technique, TIE-SESLE, have shown excellent concordance with contrast-enhanced MRA. Actually, Timus Lab showed pretty promising sensitivity and specificity, around 74 and 93% respectively, compared to CTA.
Interesting. So CTA first, MRA for specific cases. What about traditional angiography? Does it still have a role?
Absolutely. Catheter-based angiography remains vital, especially for really meticulous preoperative planning or to better delineate those distal renal artery branches that might be unclear on the cross-sectional imaging.
Okay.
This is another strong recommendation. Grade 1, quality of evidence C. Three-dimensional rotational angiography in particular can offer significant advantages in planning the optimal working angles for evaluating the aneurysm's neck, the feeding arteries, branch relationships. It's actually shown to be beneficial in about 3/4 of cases over standard two-dimensional angiography.
Wow.
And it's also superior for visualizing those tiny distal microaneurysms that CTA might miss because of rapid background enhancement.
Okay, so just to recap this section quickly, the key here seems to be a tiered imaging approach. CTA is your primary tool. MRA steps in for specific patient contraindications like pregnancy or renal issues. And then catheter-based angiography is for that really intricate planning or visualizing those hard-to-see distal lesions.
That sums it up nicely. Precision imaging leading to precision planning.
Right. So let's integrate this with a quick active learning question for you, the listener. Imagine you have a 32-year-old pregnant patient. She presents with new-onset hypertension, and a suspected renal artery aneurysm was incidentally found on a routine abdominal ultrasound. What is the most appropriate next diagnostic imaging modality, and why?
Okay, thinking about that, the answer has to be non-contrast enhanced MRA.
And the rationale?
Well, it's a grade 1, quality C recommendation, specifically because of her pregnancy. That pregnancy is a contraindication to the iodinated contrast needed for CTA, and also the gadolinium used in conventional MRA. Non-contrast MRA avoids those risks.
Perfectly explained. Now, that precision naturally leads us to the critical question of when to intervene on these RAAs. Let's talk size criteria and other indications.
Okay. So for non-complicated RAAs in patients who have an acceptable operative risk, the guidelines suggest treatment for aneurysms greater than 3 centimeters.
Suggest, so not a strong recommendation.
Exactly. It's a grade 2 quality C recommendation, conditional. This reflects that, frankly, the supporting literature is limited, so variation in care based on individualized clinical decision-making is acceptable here. It's not a hard and fast rule.
But what about emergencies?
Well, that's different. Emergent intervention is strongly recommended. Grade 1, quality B for any size RAA that's causing symptoms or critically has ruptured.
And the stakes are high there.
Extremely high. Ruptured RAAs are devastating. We're talking roughly 10% mortality in the general population, but during pregnancy, it's staggering around 55% maternal mortality and 85% fetal mortality.
Just awful numbers.
Yeah. So emergent surgery is paramount to prevent exsanguination. You might even need aortic control. And unfortunately, renal salvage might not always be feasible in that scenario, making nephrectomy a potential, though obviously undesirable, life-saving consideration.
Okay, so rupture or symptoms demand immediate action. But are there other situations besides size where intervention is indicated?
Yes, definitely. There are several special indications where treatment is suggested, regardless of the aneurysm's diameter.
Like what?
First, for women of childbearing potential, treating non-complicated RAAs is suggested, regardless of size. This is grade 2, quality B. It acknowledges the historical rupture risks during pregnancy, even though contemporary reports show improving maternal and fetal outcomes with modern interventions.
Okay, childbearing potential. What else?
Medically refractory hypertension, especially when there's also functionally important renal artery stenosis. In these cases, treatment is suggested regardless of the RAA size. That's grade 2, quality C.
Hypertension is common in RA patients, right?
Very common, about 2/3 of patients. And clinically relevant renal artery stenosis is seen in maybe 7 to 66%, depending on the study.
And do we know why RAAs cause hypertension?
There are hypotheses, Maybe distal parenchymal embolization from the aneurysm, maybe compression or kinking of the artery, or maybe just hemodynamic changes from turbulent blood flow. What we do know is that most series suggest RAA reconstruction can significantly improve or even cure hypertension in the majority of these patients, especially if renovascular hypertension is clearly identified preoperatively.
That's fascinating. So those specific patient factors, childbearing potential, refractory hypertension with stenosis, can absolutely override the simple size criteria.
Precisely.
And just for context on natural history, modern rupture rates for non-operative RAAs seem quite low, maybe 3 to 5%, and growth is slow.
Generally, yes. Median annualized growth rates are often reported between 0.06 and zero point 0.6 millimeters. Rupture during surveillance of non-operative RAAs is rare in modern series.
What about different types, like saccular versus fusiform?
Well, current literature doesn't clearly delineate different behavior for, say, branch or saccular aneurysms versus main artery fusiform ones. But classic teaching has always associated those saccular or branch aneurysms with a potentially more aggressive rupture risk, which sometimes leads clinicians to lean towards invasive treatment regardless of size, though the evidence for that specific distinction is limited.
Okay, let's do a quick micro recap for this section. The decision to intervene on an RAA isn't solely about hitting 3 centimeters. Rupture, symptoms, being of childbearing potential, or having refractory hypertension with stenosis are all critical drivers for intervention, even for smaller aneurysms. That 3 centimeter threshold is, as you said, a weak recommendation, allowing for clinical judgment.
Exactly. It's a nuanced decision.
All right. Time for another active learning check-in for our listeners. An asymptomatic 60-year-old male is found to have a 2.5 centimeter saccular RAA, incidentally. He has well-controlled hypertension. Based purely on the guidelines, what is the initial management strategy and what factors might prompt a change down the line?
Okay, based on the guidelines, asymptomatic, 2.5 centimeters, well-controlled hypertension. The initial management strategy would be observation.
And the evidence grade for that.
That's based on that grade 2 quality C recommendation for intervention, generally being above 3 centimeters. So below that, observation is the suggestion.
And what might change that?
Several things. If it grew to be greater than 3 centimeters on surveillance, if he developed symptoms related to the aneurysm, or heaven forbid it ruptured, or if it demonstrated significant interval growth during surveillance, the guidelines often mention something like greater than 0.5 centimeters per year as a potential trigger for reconsideration.
Excellent. Okay, let's move on to the actual treatment options for RAAs. What do the guidelines say here?
Well, starting with medical management, there's actually a suggestion for daily antiplatelet therapy, like 81 milligrams of aspirin, for patients with RAA. This is grade 2, quality C.
Okay, aspirin. What about definitive repair? Open surgery.
Open surgical reconstructive techniques are suggested for elective repair of most RAAs in patients with acceptable operative risk. That's grade 2, quality B.
And what does that entail?
Oh, there's a range of conventional in situ reconstructions, things like aneurysm resection with primary angioplastic closure, maybe with or without branch reimplantation patch, angioplasty, primary reanastomosis, interposition bypass using vein or prosthetic, aortorenal bypass, even splanchnic renal bypass in some cases. For small aneurysms, simple plication might even be an option.
And the outcomes for open surgery.
Historically very good in experienced hands, consistently low elective mortality rates, often approaching 0%, perioperative morbidity generally less than 20%, and importantly, durable primary patency rates 93 to 100% reported in many series, and excellent projected long-term survival.
How do you choose which technique?
The technical approach should really be dictated by the anatomy. While there's no prospective data comparing all these techniques head-to-head, some retrospective data suggests angioplastic repairs might have superior patency over, say, saphenous vein interposition grafts.
What about protecting the kidney during clamping?
Yeah, it's common practice to use cooled renal perfusion, especially if you anticipate warm ischemia times exceeding 30 to 40 minutes, although there isn't prospective data definitively proving its benefit in all cases.
Okay, what about really complex aneurysms, maybe involving distal branches?
For those complex distal branch aneurysms, ex vivo repair and autotransplantation are suggested over nephrectomy when it's technically feasible. That's grade 2, quality B.
Ex vivo, so taking the kidney out.
Exactly. Repairing it on the bench, then putting it back, usually in the iliac fossa. Larger series report high success rates, like 92%, with no mortality and minimal major morbidity. Some centers even do the nephrectomy laparoscopically to avoid the large incision morbidity, then do the bench repair and autotransplant.
Fascinating technique. Now, what about less invasive options? Endovascular.
Endovascular techniques are also suggested for elective repair of anatomically appropriate RAAs. That's another grade 2 quality B recommendation. This includes things like stent graft exclusion for main RAAs, especially in patients who are poor operative risks, and embolization, usually with coils or liquid agents, for distal and parenchymal aneurysms.
The technology there has evolved a lot, hasn't it?
Tremendously. We now have three-dimensional detachable coils, non-adhesive liquid embolic agents like Onyx, various remodeling techniques including balloon-assisted and stent-assisted coiling, and even flow diverter stents being used or investigated.
How do the outcomes compare to open?
Technical success rates are generally high,
Mhm.
73 to 100%, but morbidity is highly variable, reported anywhere from 13 to 49% in different series. There are concerns like coil migration and organ ischemia causing parenchymal infarcts, and the risk of endoleak or aneurysm reperfusion later on, which might require reintervention.
So potential downsides to consider. What about robotic or laparoscopic approaches?
Yeah, those are mentioned too. Laparoscopic and robotic techniques are suggested as an alternative based on institutional resources and surgeon experience with minimally invasive techniques. That's great too, quality C.
What's the advantage?
Well, proponents say you need a good multidisciplinary team, but the robotic arms reportedly offer a technical advantage for complex aneurysmectomy and doing the fine intracorporeal vascular suturing. Reported warm ischemia times are typically between 15 and 60 minutes. But again, there's a lack of direct comparative data with open or other endovascular techniques right now.
Okay, let's do another micro recap. Treatment for RAAs really covers a wide spectrum. Medical management with aspirin, traditional open reconstructions, complex ex vivo repairs, a growing range of endovascular techniques, and even minimally invasive robotic approaches. The choice seems highly individualized, balancing the patient's operative risk, the specific aneurysm anatomy, and the critical need for precision, always with a focus on preserving renal function and being aware of potential complications like end organ ischemia or endoleaks.
That's a great summary. Highly individualized care is key.
All right, another clinical challenge for our listeners. You have a 55-year-old male with multiple comorbidities. He's found to have a saccular renal artery aneurysm right at a main renal artery bifurcation measuring 3.5 centimeters, and he's symptomatic with abdominal pain. Which treatment approach is likely preferred here, and why, considering his comorbidities and the aneurysm's location?
Okay, multiple comorbidities, symptomatic, 3.5 centimeters at a bifurcation. Given his comorbidities making open surgery higher risk, and the fact that he's symptomatic needing treatment, an endovascular approach would likely be preferred. Specifically, stent graft exclusion seems most appropriate here. That aligns with the grade 2, quality B suggestion. The goal would be to exclude the saccular aneurysm while preserving flow down the main renal artery branches, minimizing the morbidity associated with open surgery in this higher-risk patient. The bifurcation location makes simple coiling potentially tricky, favoring a stent graft.
Makes sense. Now, shifting gears slightly, screening. If you find an RAA, should you look for other aneurysms?
Yes, the guidelines address this. It's particularly important because RAAs can be associated with fibromuscular dysplasia, FMD, which is a systemic arterial disease. So the guidelines suggest a one-time screening for occult aortic or other arterial aneurysms in patients with RAA, especially if FMD is suspected or diagnosed. That's grade 2, quality B. Remember, FMD can affect other vascular beds like the carotids or vertebrals, so symptoms like migraine, tinnitus, or neck pain might also be clues pointing towards FMD.
That's a really crucial point. Don't just treat the RAA in isolation. Remember to screen for other aneurysms, especially if fibromuscular dysplasia might be involved, because it is a systemic condition.
Couldn't agree more.
Finally, for RAAs, let's talk follow-up and surveillance. What's recommended?
Okay, after open surgical reconstruction, completion imaging before hospital discharge is suggested. Ideally with axial imaging like CTA or MRA, though arteriography might be used in select cases. This is grade 2, quality C. Modern axial imaging can often replace traditional arteriography or ultrasound for these completion studies, and long-term surveillance imaging is also suggested.
What about patients who are managed non-operatively? Just observation.
For those patients, the suggestion is annual surveillance imaging until you have 2 consecutive studies showing stability. After that, the surveillance interval may be extended to every 2 to 3 years. That's grade 2, quality B.
Okay, so whether you operate or observe, consistent follow-up imaging is key for RAA patients. More frequent initially, then potentially spaced out once stability is confirmed.
Exactly. Diligent surveillance is crucial.
All right, let's try to synthesize everything we've discussed about renal artery aneurysms in a mega recap.
Okay. I think what's truly fascinating here is seeing how the management of renal artery aneurysms has evolved. We've really moved from a time when open surgery was basically the only option to a much more nuanced approach today. We leverage advanced imaging like CTA and MRA for incredibly precise diagnosis. We consider individual patient factors like being of childbearing potential or having refractory hypertension as reasons to intervene even at smaller sizes. And we now have this broad spectrum of treatment modalities, from those classic open repairs to highly technical endovascular options, and even robotic surgery is entering the picture. But through it all, the emphasis remains squarely on meticulous planning, always striving to preserve renal function and maintaining diligent long-term surveillance to monitor for any growth or complications. It really reflects the nature of these lesions, often rare, often asymptomatic, until that potentially catastrophic rupture. 2. Splenic artery aneurysm, SAA.
A deep dive?
Excellent summary. Now let's shift our focus to the second major area, splenic artery aneurysms, or SAAs. Similar to RAAs, are we finding more of these incidentally now? Yes, absolutely. We're seeing an increasing diagnosis of incidental SAAs, and it's primarily due to the liberal use of cross-sectional imaging studies performed for other reasons. Most SAAs detected today are found this way, highlighting their often silent nature until something goes wrong.
And the diagnostic tools, is it similar to RAAs?
Pretty similar, yes. Computed tomography angiography, CTA, is again reinforced as the initial diagnostic and evaluative tool of choice for SAAs. That's grade 1, quality C.
And if contrast is an issue?
Then magnetic resonance angiography, MRA, is recommended for patients with suspected SAAs and pre-existing renal insufficiency that limits the use of iodinated contrast material. Also grade 1, quality C. Although some older studies did raise concerns about MRA sensitivity for really small aneurysms compared to CTA.
Okay. And arteriography?
Arteriography is recommended when those non-invasive studies haven't sufficiently demonstrated the status of relevant collateral blood flow, or, importantly, when endovascular intervention is actually being planned. That's grade 1, quality B. It's very frequently used right at the time of a planned endovascular procedure.
Got it. So another quick micro recap for diagnosis. Similar to RAAs, CTA leads the way for SAA diagnosis. MRA is the go-to for contrast-sensitive patients. And arteriography is reserved for that detailed pre-interventional planning, especially focusing on collateral flow or as part of the intervention itself.
Precisely.
Okay, listener challenge time again. A 40-year-old male with chronic kidney disease presents with a suspected splenic artery aneurysm. Which imaging modality should be chosen first, and what considerations are paramount?
All right, chronic kidney disease is the key here. So magnetic resonance angiography is recommended due to his renal insufficiency, specifically to avoid that iodinated contrast. Grade 1, quality C. The paramount consideration is getting an accurate diagnosis without further compromising his renal function.
Perfect. Now let's get into the really critical part for SAAs. Treatment indications, size criteria, and the difference between true and false aneurysms. What's the most urgent scenario?
Rupture, without a doubt. Emergent intervention is strongly recommended for any ruptured SAA. This is a high-confidence, grade 1 recommendation, and importantly, it's backed by high-quality evidence, quality A, reflecting just how life-threatening rupture is.
Okay, rupture is an emergency. What about pseudoaneurysms, the false ones?
For non-ruptured splenic artery pseudoaneurysms, treatment of any size is recommended in patients of acceptable risk. That's grade 1, quality B.
Any size. Why?
Because pseudoaneurysms have an inherently increased risk for rupture compared to true aneurysms, and importantly, their diameter isn't necessarily a reliable predictor of rupture. So you find one, you treat it, generally speaking.
Got it. Pseudoaneurysms get treated. Now, what about true aneurysms? Are there specific criteria?
Yes, several important ones. First, women of childbearing age. For them, treating non-ruptured splenic artery true aneurysms of any size is recommended. Grade 1, quality B.
Regardless of size again?
Yes, because of that significant risk of rupture during pregnancy we talked about earlier. Remember those historical mortality figures. While outcomes are better now, the risk is still considered substantial enough to warrant treatment. For pregnant women specifically, treatment decisions should be individualized regardless of size, considering the potential morbidity to both mother and fetus that's noted as an ungraded best practice statement.
Okay, so childbearing age is a major factor. What about the general population with true SAs?
For the general population, the recommendation is to treat non-ruptured splenic artery, true aneurysms that are greater than 3 centimeters, or those that have a demonstrable increase in size on surveillance, or those that are causing associated symptoms, assuming the patient is of acceptable operative risk. That's grade 1, quality C.
So the 3-centimeter threshold appears again similar to RAAs, but as a grade 1 recommendation here, albeit lower quality evidence. What about not treating?
Observation is suggested over repair for small, meaning less than 3 centimeters stable, asymptomatic splenic artery, true aneurysms. Or, alternatively, in patients who have significant medical comorbidities or limited life expectancies, where the risk of intervention might outweigh the benefit. That's grade 2, quality C. And an important note, aneurysm calcification isn't firm evidence protecting against growth or rupture. Don't rely on that.
Good point about calcification. Are there any other suggested indications for intervention?
Yes, the guidelines also list a few others where intervention might be considered. Patients with portal hypertension, candidates for liver transplantation, those with aneurysms thought to be from a non-atherosclerotic or non-degenerative cause, like mycotic or inflammatory, and aneurysms demonstrating interval growth greater than that 0.5 centimeters per year threshold.
Okay, let's try a micro recap for SAA indications. For SAAs, any rupture is an absolute emergency. Pseudoaneurysms get treated regardless of size. True aneurysms in women of childbearing age also get treated regardless of size. For everyone else with true aneurysms, the 3-centimeter mark, documented growth, or symptoms are the key triggers for intervention, grade 1. But observation for small, stable, asymptomatic lesions, especially in high-risk patients, is a reasonable option, grade 2.
That captures the key decision points well.
All right, let's test that understanding. A 68-year-old male with a history of significant cardiac comorbidities is incidentally found to have a 2.5-centimeter asymptomatic true splenic artery aneurysm. He also has a limited life expectancy. What is the most appropriate management and why?
Okay, so elderly comorbidities, limited life expectancy, small, 2.5 centimeter, asymptomatic true SAA. Given the specific clinical picture, observation is suggested.
Then the reasoning.
It falls under that grade 2 quality C recommendation. The aneurysm is small, stable, asymptomatic, and critically, his comorbidities and limited life expectancy mean the risks associated with an intervention likely outweigh the potential long-term benefits of repairing this small aneurysm.
Makes perfect sense. Okay, now let's discuss the actual treatment options for SAAs. How do you approach repair?
Generally, treatment can be done using either open surgical or endovascular approaches. The main goal, always, is to prevent expansion and rupture by excluding the aneurysm from the arterial circulation, while critically maintaining necessary perfusion to the distal organ, the spleen, or relying on collateral beds.
Let's start with open surgery. What are the techniques?
Okay, if you encounter a ruptured SAA at laparotomy, the suggestion is treatment with ligation, possibly with or without splenectomy, depending on exactly where the aneurysm is located along the splenic artery. That's grade 2, quality B.
And for elective open repair?
For elective treatment, open surgical methods are certainly appropriate, again, grade 2, quality B. The traditional management for aneurysms in the proximal or middle part of the splenic artery is usually proximal and distal ligation, and sometimes aneurysmectomy.
Do you need to revascularize the spleen after ligation?
Generally, no. Revascularization of the distal splenic artery is not routinely required. That's grade 2, quality C. This is because there's usually sufficient collateral blood flow from the short gastric arteries coming off the stomach to keep the spleen perfused.
What about aneurysms way out near the spleen, or infected ones?
Right, for those more distal lesions adjacent to the splenic hilum, and also for mycotic aneurysms, excision, often including a splenectomy, has traditionally been the most common operation. That's grade 2, quality C. Distal pancreatectomy might occasionally be warranted too if the aneurysm involves the pancreatic tail.
Why open surgery specifically for those distal ones?
The preference for open over endovascular methods for these distal SAAs near the hilum stems from concerns about end organ ischemia specifically, splenic infarction, and pancreatitis, which can be higher risk with endovascular techniques in that delicate hilar region.
Can open repair be done minimally invasively?
Yes, laparoscopic repair by clipping or exclusion has been described, and intraoperative ultrasound is noted as an important adjunct to help identify the vessels accurately during laparoscopy.
Okay, now let's switch to endovascular techniques for SAAs. When are they used?
For elective treatment, using an endovascular approach is suggested if it's anatomically feasible. Grade 2, quality B. This usually involves techniques like stent graft placement across the aneurysm neck, or more commonly, coil embolization to fill the aneurysm sac and potentially occlude inflow-outflow vessels.
What are the potential downsides of endovascular SAA repair?
There are definite drawbacks to be aware of. The potential for end organ embolization, particularly causing splenic infarction or pancreatitis, is real. There's also a relatively higher rate of technical failure or recurrence requiring reintervention compared with open surgery in some series. And patients can also develop post-embolization syndrome characterized by pain, fevers, systemic inflammatory symptoms, which usually resolves but can be unpleasant.
How does endovascular compare overall to open? Cost, quality of life.
That's an interesting point. One Markov decision model analysis that was cited suggested endovascular repair was associated with the highest quality of life and was the most cost-effective strategy for most patient groups, though it did suggest that for some elderly patients, conservative therapy might still be considered. However, the guidelines still note that an open surgical approach may remain appropriate, especially for rupture, for pregnancy-related SAs, and for mycotic aneurysms.
Right. And we absolutely have to mention vaccination.
Critically important, yes. For urgent ligation or splenectomy, patients should be vaccinated on or after postoperative day 14 against Streptococcus pneumonia, Haemophilus influenzae type B, and Neisseria meningitis.
And for elective cases?
For elective repair, where splenic loss is considered a significant risk, or maybe if there are preoperative anatomic challenges that might necessitate a fallback embolization strategy that could compromise the spleen, vaccination should be considered at least 14 days before the planned intervention. It's a key safety step.
Absolutely crucial. Okay, quick micro recap on SAA treatment. Options range from open ligation or excision, sometimes with splenectomy, especially distally or for rupture, to endovascular coil embolization or stent grafting. Endovascular is often preferred electively when feasible due to lower initial morbidity and potential cost-effectiveness, but carries risks like splenic infarction or pancreatitis and maybe higher failure rates. Open surgery remains vital for rupture, pregnancy, mycotic aneurysms, and complex distal cases. And don't forget the vaccination protocol if splenectomy is performed or anticipated.
Excellent summary. Covers all the key points.
All right, one last active learning question for SAAs. A 30-year-old non-pregnant woman presents with a 2.5 centimeter true splenic artery aneurysm located distally near the splenic hilum. She is otherwise asymptomatic. Given the guidelines, what is the recommended management strategy and why is the location so important?
Okay, 30 years old, woman of childbearing age, 2.5 centimeters, true SAA. Treatment is recommended regardless of size because she's of childbearing potential. That's the grade 1, quality B recommendation.
Right, and the location.
The location distally, near the splenic hilum, is key. Given that location, open surgical techniques, possibly including splenectomy, are suggested over endovascular methods. That's the grade 2, quality C guidance. The reason is that specific concern for causing splenic infarction and pancreatitis with endovascular maneuvers right at the hilum. Open repair is often considered safer in that anatomical spot.
Great explanation. Now, similar to RAAs, what about screening for other aneurysms if you find an SAA?
Yes, the guidelines suggest screening patients with SIAs for other intra-abdominal, intrathoracic, intracranial, and peripheral artery aneurysms. This is grade 2, quality B.
Is it common to find others?
Surprisingly common. One large series highlighted that 3.3% of SAA patients had concomitant visceral aneurysms, most commonly extrahepatic artery aneurysms, but also celiac, superior mesenteric, gastric, pancreaticoduodenal, and even more striking, 14.3% had concomitant non-visceral aneurysms.
14%. What kind?
Most commonly renal and abdominal aortic aneurysms, but also carotid, intracerebral, thoracic aortic, and popliteal aneurysms were found. It really underscores that aneurysmal disease can be a systemic process.
Wow, that's a huge takeaway. The presence of a splenic artery aneurysm should absolutely trigger a broader search. Remember that other visceral and non-visceral aneurysms are surprisingly common concurrently.
Definitely a key point for clinical practice.
And finally, for SAAs, follow-up and surveillance.
For patients managed non-operatively, the suggestion is annual surveillance with computed tomography or ultrasound to assess for any growth. That's grade 2, quality B.
And after endovascular treatment?
After endovascular intervention, periodic surveillance with CTA, ultrasound, or MRA is suggested. The goal here is to assess for endoleak or continued aneurysm perfusion, which could lead to continued growth or even rupture risk down the line. Also grade 2, quality B.
Is failure common after endovascular SAA repair?
Well, there are concerns about treatment failure, including things like persistent perfusion of the sac, endoleak, recanalization of coiled vessels, or even coil migration. These possibilities necessitate early and then serial imaging follow-up. One practical point, artifacts from the radiopaque coils or stents can sometimes make sensitive CTA evaluation difficult, suggesting that contrast-enhanced ultrasound or perhaps MRI might be good alternatives in some cases for follow-up.
Okay, so whether observed or treated endovascularly, splenic artery aneurysms require ongoing surveillance with appropriate imaging to catch any growth, endoleaks, or reperfusion that could signal future trouble.
Vigilance is key, yes.
All right, let's wrap up the SAA section with a mega recap, synthesizing everything.
Okay, I think the management of splenic artery aneurysms, much like RAAs, really underscores a highly individualized and vigilant approach. We have strong recommendations for emergent intervention in rupture cases, grade 1A, and clear guidance to treat all pseudoaneurysms and true aneurysms in women of childbearing age, regardless of size, grade 1B. These guidelines provide those critical thresholds. While endovascular techniques have certainly gained favor for elective repair due to potentially lower morbidity and maybe cost-effectiveness, grade 2B suggestion, open surgery absolutely retains its vital role, particularly for those complex distal lesions near the hilum or in emergency settings like rupture, or for specific situations like pregnancy or mycotic aneurysms. And crucially, recognizing the systemic nature of aneurysmal disease means that comprehensive screening for other aneurysms, grade 2B, and diligent long-term tailored surveillance, grade 2B, aren't just afterthoughts. They are integral components of providing optimal patient care for SAAs.
That's a fantastic synthesis. This deep dive, I think, has really illustrated the meticulous, evidence-based approach the Society for Vascular Surgery guidelines provide. It offers clinicians that much-needed synthesized guidance for managing these genuinely challenging conditions. It feels like a real move beyond just anecdotal evidence towards actionable recommendations.
I agree completely. By synthesizing information from, 80 observational studies and over 2,800 aneurysms, these guidelines manage to distill incredibly complex data into clearer, actionable pathways. And it's important to see them as reflecting a dynamic living document, something that adapts as our techniques, technology, and data continue to evolve over time.
Absolutely. So as we wrap up, a final provocative thought for you, our listener. As we continue to benefit from these increasingly precise diagnostic imaging tools and less invasive treatment modalities for visceral artery aneurysms, the question remains, how can we best leverage emerging technologies, perhaps artificial intelligence and predictive analytics, to further refine our understanding of their natural history? How can we better individualize risk assessment, particularly for that vast majority of incidentally discovered asymptomatic lesions? Could this help us optimize intervention timing and tailor surveillance strategies in an even more precise and resource-conscious way in the future?
That's the frontier, isn't it? Moving towards even more personalized prediction and prevention. A fascinating thought to end on.